Vertebral basilar stroke and manipulation, and yet another misguided study. A new study has surfaced attempting to implicate manipulation as a cause of VBA stroke. The bias is apparent not only in the design, but also in the wording of the results and conclusions. And compared to prior studies, it's a small study with inadequate comparisons. Unfortunately, they seem to dismiss not only prior larger study findings, but the conclusions of a well-designed review in the Annals of Medicine. The title is Chiropractic-Associated Vertebral Artery Dissection, an analysis of 34 patients amongst a cohort of 310, published in Clinical Neurology and Neurosurgery. It begins with this statement in the results, quote, overall, 34 out of our 310 patients suffered a chiropractic-associated injury, unquote. Yet again, an esteemed group of physicians falls victim to the cause and effect illusion of time coupled with protopathic bias. That is, their assumption is that because the strokes occurred after a visit to the chiropractor, that not only did the chiropractor manipulate the neck, but that this was the cause. Given cause and effect can only be studied using prospective randomized trials, this study, like all studies of this rare occurrence, can only identify an association. And then the protopathic bias. This is defined as seeing a healthcare provider during the prodrome of a condition, before the presentation becomes obvious enough to warrant further evaluation, before it can be diagnosed. In the case of dissection, the presentation of neck pain or headache prior to progression to stroke, and with no clinical test to detect during this phase. Another red flag is that theirs is not the usual structure of an abstract. An appropriate abstract structure intentionally avoids interpretations and focuses on conclusions based on the evidence, not conjecture. This abstract contained a deviation from the normal structure, which includes background, methods, results, and interpretation, compared to what is usually objectives, methods, results, and conclusions. And additionally, there are no key terms. Like all studies, though, there are important items of interest that we will review. Before we take a deeper dive into the design and results, let's emphasize some of the statistics they present in this study. Cervical artery dissections include carotid and vertebral artery dissections, which together account for 10 to 25% of ischemic strokes in patients under 50 years old. The incidence of carotid artery dissection is estimated to be 1.7 per 100,000 per year, while the incidence of vertebral artery dissection is approximately 1 per 100,000 per year. They note that these dissections can arise spontaneously or due to trauma. Now to the study. Who were the patients? Well, between January 2004 and December 2018, VBA stroke patients were identified using the Northwestern University Electronic Data Warehouse. And again, according to the researchers, among the 310 patients, 34 patients had a cervical chiropractic-associated, quote, injury, unquote. A VAD was considered chiropractor-associated if recent chiropractic manipulation was noted in the initial emergency department or first clinic note. The researchers also used an outcome measure of disability. The primary measurement of neurologic status used was the modified Rankin scale. It's a measure of the degree of disability in daily activities in those who suffered a stroke. The MRS was calculated at discharge, 3-month follow-up, and last follow-up. And now the results. Only 11%, 34, of the total 310 VBA patients had a chiropractor-associated VBA. That means that 89% did not. These patients were younger than patients with other causes of VAD, usually in the age group of late 30s to late 40s. Females were more often affected by chiropractic-associated VBAs, comprising 85.3% of the cohort. Other prior studies have shown male predominance. Smoking status was equal among all VBA patients. Other cause VADs in the study include dissections caused by trauma, which included motor vehicle accidents, falls, violence, exercise, etc., and those that arose spontaneously, although there was no consideration by the authors that the dissection could have occurred prior to the chiropractic visit and therefore be spontaneous. And to more results and assumptions, they state that chiropractor-associated VADs appeared to be bilateral more frequently, but it was not statistically significant. And they state that chiropractor-associated VADs seemed more likely to involve the extradural segments V1 through V3 of the vertebral artery, although the result was again not statistically significant. Chiropractic VADs resulted in shorter initial hospital stays. At discharge, 3 months, and last clinic follow-up, the modified Rankin scale of the chiropractor group was lower than the other cause group. A 2018 study found that 11% of women in the United States had visited a chiropractor in the last 12 months compared to 9.4% of men. This certainly does not account for their explanation of the higher incidence of women in their study, and again, it was not statistically significant. There are many fatal design flaws in the study. If the researchers state that chiropractic manipulation is an associated risk, demonstrated only by retrospective studies, then how is it that they conclude that chiropractic manipulation causes VBA stroke? And why do they ignore the past evidence that in much larger studies it has repeatedly been demonstrated that there is an equal or greater risk for patients seeing an MD compared to seeing a chiropractor? Why do they assume that all patients were physically adjusted or manipulated? In other words, manipulation might be instrument-assisted. And how do they not study the presentation of patients to determine, as past studies have, if patients are already in dissection, which produces a visceral referral to the head and neck in 80% of patients, that then leads to seeking chiropractic or medical care? And why not compare to medical visits? Well, 2 very large studies did, with study populations in the millions. The seminal study, Risk of Vertebral Basilar Stroke and Chiropractic Care, results of a population-based case control and crossover study by Cassidy et al. In Spine, 2008. There were only 818 hospital-reported VBAs in the entire population of Ontario over 9 years. In those under 45 years old, individuals were 3 times more likely to see a chiropractor or a primary care practitioner before their stroke compared to controls. There was no increased association between VB stroke and chiropractic visits in those older than age 45. There was an association between VB stroke and patients of all ages visiting a PCP prior to stroke. And given medical doctors do not manipulate or adjust necks, the only reasonable explanation is that patients are presenting in dissection. And yet another study in the United States entitled Chiropractic Care and the Risk of Vertebral Basilar Stroke, results of a case control study in U.S. commercial and Medicare Advantage populations. There were only 1,829 VBA strokes over 3 years. The prevalence in the over 35 million commercially insured group was 0.021%, and in the over 3 million Medicare Advantage group, 0.0032%. In summary, the data indicates that there is no association, on average, between chiropractic visits and VBA stroke, regardless of age stratification in either the commercial or Medicare Advantage populations. However, there was a significant statistical association between PCP visits and VBA stroke, regardless of length of hazard period. The researchers also ignore a systematic review published in 2019 in the Annals of Medicine. The title is A Risk-Benefit Assessment Strategy to Exclude Cervical Artery Dissection in Spinal Manual Therapy, a Comprehensive Review. The authors state, quote, in light of the evidence provided in this comprehensive review, 1. No firm scientific basis for direct causality between cervical spinal manipulative therapy and cervical artery dissection. 2. The internal carotid artery moves freely within the cervical pathway. 3. 74% of cervical SMTs are conducted in the lower cervical spine, where the VA also moves freely. Remember, the study we are reviewing claims that the damage is higher at the V3 segment. 4. Normal activities of daily living, including rotations, do not trigger CAD. And 5. Cervical manipulation and or grade C cervical mobilization moves beyond the physiological limits of facet joints, but the artery is not stretched to an extent to exceed failure strain. Where did they find the evidence? Here's one publication by Herzog, Vertebral Artery Strains During High-Speed, Low-Amplitude Cervical Spinal Manipulation. Here we can see the different segments of the vertebral artery, V1 through V4. Here we see the strains from range of motion testing compared to cervical manipulation testing. It's clear that the strains occur more at the V1 segment, where most chiropractic adjusting occurs, compared to the V4, close to the V3 segment, which in fact is strained more by range of motion testing. What about microstructural damage? Well, here we can see a study titled Microstructural Damage in Arterial Tissue Exposed to Repeated Tensile Strains. They found no damage at 6% of strain, but according to the available literature, spinal manipulative therapy strains range from 0.9 to 6.2%. In fact, it took 1,000 cycles of 30% strain to cause significant microstructural damage in the arterial tissue. Also, the study fails to recognize what we already know, that about 80% of individuals have pre-stroke complaints during dissection that include headache and neck pain, often described as first and worse. The prognosis of cervical artery dissection is also misunderstood. At 3 months, the prognosis is actually good for about 89% of cases. The mortality rate is less than implied. The mortality rate is a mean of 5.1% for internal carotid artery dissection and a mean of only 1.3% for vertebral artery dissection. And why is it that the opinion of the World Health Organization is ignored? Quote, considers manual mobilization and or spinal manipulative treatment conducted by chiropractors to be a safe and effective treatment with few, mild, transient adverse events, such as local soft tissue tenderness and tiredness on the treatment day, unquote. So in summary, these researchers entered the study with the assumption that manipulation causes damage in dissection and proceeded with that hypothesis. They never considered that the associated stroke was coincidental, meaning that the patients may have been in dissection at the time of presentation to the chiropractor and therefore had headache or neck pain and were seeking help from a healthcare provider. And with that possibility, these researchers should have compared results to patients who had seen a medical doctor within the same time period. The question really should be, is there any way to detect someone that might be in dissection and refer for evaluation? And the answer, unfortunately, is there is no test in office. From what we do know, historically, if a middle-aged patient with a new onset of headache or neck pain that the patient describes as the worst pain they have had in that area, further investigation is warranted prior to treatment. Also, it's been suggested that patients with inherited collagen vascular disease or acquired vasculitis through infection or autoimmune processes not be manipulated. It would be helpful, though, to investigate if these hypothetical contributors are present in any reported cases. Otherwise, in general, it might be prudent simply to refer patients with new headache and neck pain that has no obvious cause and is new and severe.